But it's supposed to be nice.
Yeah.
I think we put up a bunch of chairs so all you guys can sit there.
I had my spectrum practically on.
That'll look good. That'll look good.
Only one person watching.
It's me, actually.
Check it out. Hey, do we have some water?
The last two, in case we need them.
Great, thank you.
Yeah.
I appreciate Yeah.
All right. So this is a joint meeting of the Community Healthcare Investment and Consumer Involvement Committee and the Cost Trends and Market Performance Committee. I'm delighted to see everyone here. I hope everyone had a wonderful holiday. I hope everyone got a little bit of time off because it's quite busy around here. So I guess I'll start off, but I'm happy I'm happy to share the water with anyone who wishes to have some. But the first item we have to do is to approve the minutes. So the only minutes that are here to be approved are the ones from the May 31st meeting of the Cost Trends Market Performance and CHICI joint meeting. So if anyone has any suggestions or addendums to that, and that would be the time to say so. If not, then we need a motion to approve the minutes. Anyone second? Okay, all those in favor? Any in opposition? Okay, we unanimously approve the minutes. The bulk of today will then be spent on a couple of issues. One is the HPC DataPoints presentation. We've actually got some great stuff. I was looking at it over the break. So I'm excited about this stuff. So we'll turn to that. And then the 2017 cost trends hearing. And then finally we'll actually get to hear a little bit about the Boston healthcare for the homeless and how they're addressing the issues that have come up and what sorts of things HPC could do to help them out. So maybe what I should do, am I turning over to you, David, for the data presentation? Thank you.
Great. Good morning, commissioners. Good morning, everyone joining us today, everyone on the live feed. I hope everyone had a very nice holiday. It's great to be back. So for today, for our joint meeting, we have, as Commissioner Butler laid out, really kind of two sides to the agenda. On one side is very much in the data and in the cost trends side of the joint committee. And the second half of the presentation is more focused on our investments and our awardees. And so pleased to have representatives from Boston Healthcare for the Homeless to talk about their initiative that they're working on, which is funded through our Healthcare Innovation Investment Program. But the first part of this is really to share some data and some information with this joint committee, get your feedback and input on this work, answer questions you may have. So really view this as an opportunity to kind of have a dialogue and a discussion over some of these different data presentations we'll go through. That will lead into hopefully a little bit of a conversation we can have about the cost trends hearing. It is time to start planning for the cost trends hearings again. So they are scheduled for October 2nd and 3rd. So have teed up just kind of a conversation starter. You know, what are some of the themes that the committee members are interested in this year? How can we think about continuously updating and improving those hearings to maximize their impact? So we'll have a conversation around that as well. So seated to my right is the bulk of our research and cost trends team, who is going to be presenting the next part of the presentation. So I'm just going to introduce them really quickly. So my direct right is David Auerbach, who's the director of the research and cost trends team. All the way over here is Sarah Sadamic, who is the deputy director for the research and cost trends teams. And we have Natasha Reese-McLaughlin and Rachel Salzberg, who are also members of the team. Rosie Kerber here in the front row as well is a part of this team. And the last member is not here. Okay. So we're really pleased to introduce to the committee and to the public a new offering that we developed here at the HPC that we're calling HPC DataPoints. And the genesis of this idea was really that for the last 4 years we've been very skilled and at producing very large 100-page plus reports that are full of data and information that really speaks to issues around healthcare spending trends. We know that not everyone has the time to dive through a 100-page report, and that in this current media environment, and environment in how we process information news, that having some more, as they're called, bite-sized ways of presenting this information, we think can both really connect with the public in a greater way, but also to be able to be nimble in terms of some of the analysis that we can do, that we don't have to wait until the annual cost trend report once a year to kind of have all of our findings, that there are ways that we can get things out in a more quicker way, and also ways that really engage the audiences in terms of the data that we're finding. So we've introduced this on our website. It is a series of web briefs, and as you'll see in a minute, we've also used a new software, or not new software, but new for us, which is called Tableau, which, as you can see, provides an ability for the public to directly engage with the data right on the web screen and be able to do kind of their own customized look at some of the information that we have. Again, another way of trying to kind of engage the public and the audience in our work. So what we're going to do is go through, we've done 3 of these data points so far, so we're going to share with you the findings from them. They're a little bit all over the place in terms of the topics, but that is kind of a reflection of what these are. Is meant to be, can be a variety of different topical areas. After that, we do have a presentation specifically on new information that we received from the Federal Centers for Medicare and Medicaid, CMS, that shows new information about where Massachusetts stands compared to the national average and to other states when it comes to total healthcare spending. So this is new information that we're sharing for the first time here today. So with that as a long-winded introduction, I'm going to turn it over to the cost trends team to introduce you to data points, and again, encourage you guys to ask questions along the way of the expert team here. So with that, David?
Sure. I'm just going to pretty much hand this over to Natasha, but just to say, for these 3 data points we're showing you is really just a sample. We're just showing one slide of data, but there is more that you can find on the website. So this is kind of a brief overview of the 3, and then we'll go in more depth on the new CMS data as David said a second ago.
Thanks, David. So for one of our first data points, we chose to look at avoidable ED utilization in Massachusetts. As some of you might recall, in last year's cost trends report, we reported that 42% of all ED visits in Massachusetts in 2015 were considered avoidable, which is a share that's remained constant over time. So for this data point, we decided to take a deeper dive into the data to try to understand some of the characteristics of these visits. As a reminder, we identify avoidable ED visits using the NYU Billings algorithm, which categorizes ED utilization into 4 categories, 2 of which are considered avoidable. That would be the non-urgent diagnoses, so where the diagnosis suggests that the patient likely didn't need to see a medical provider within 12 hours, and primary care treatable visits, which means that the diagnosis suggests that the patient did need to see a provider, but it should have been a primary care provider. What we found is that in general, avoidable ED visits look very similar to urgent ED visits. They're predominantly women, predominantly mass health patients, predominantly adults. One area where we did start to see a little variation or divergence was when we looked at avoidable ED visits by zip code. In a lot of our analyses, we're used to seeing geographic variation, but as you can see here, avoidable ED utilization is fairly consistent across the Commonwealth, suggesting that this really is a statewide concern. One of the functionalities of Tableau that we're able to use was, if you, Andrew's going to help me show this off. We were able to look at, by zip code, the share of visits that were considered avoidable, in addition to the most common reason why patients in that zip code went to the ED for an avoidable condition. So in 2015, the 3 most common avoidable ED utilization diagnoses were acute sinusitis, stomach pain, and skin conditions, which were rashes, hives, sunburns, acne. So if we look at the northwest part of the state, you can see that New Ashford, there it is. The most common diagnosis was sinusitis, and 42% of all ED visits in that zip code were considered avoidable. If we go next door to Williamstown, which is I think above, yes, yep, oh, yep, there we go. The most common avoidable diagnosis was stomach pain, and 39% of all the ED visits in that zip code were considered avoidable. And then finally going to Adams, you can see that the most common condition was acne, and that 46% of all ED visits were considered avoidable. So it's just a fun, interactive way to help paint a picture of what exactly these types of visits were in the Commonwealth in 2015.
So when we totally unnecessary comment version of this, this is spectacular except the shading is all. Sorry, shading could use a little bit more. It's hard for me to tell apart which areas are eye.
Absolutely, yeah.
Yeah. Sorry, where is eye trouble in this?
It's in there. Well, we can try to address that. So moving on, in another data point, we chose to look at a subset of avoidable ED visits, which are avoidable health ED visits. Oral health ED visits are for conditions such as cavities, dental abscesses, and they're considered avoidable because ED ED departments are not capable of treating these patients. So oftentimes the patients arrive in tremendous pain. They're given painkillers, they're given antibiotics, so they really have to see a dentist to get treatment. Last year, we released a brief on oral health ED visits in Massachusetts in 2014. So for this data point, we extended that analysis into 2015 and also looked back in time to 2011 to try to understand some of the trends around these visits. What we found, encouragingly, is that oral health ED visits in Massachusetts have declined over time. They declined about 11%. However, that was not consistent across all age categories. So for children between the ages of 5 and 10 and seniors between the ages of 64 and 74, there's a 15% increase in these types of visits. In seniors ages 74 and older, there was a 4% increase. One new analysis that we did for the blog that we did not include in the brief was we also looked at oral health ED visits by median community income. So we divided all the zip codes in Massachusetts into 4 income quartiles. And as you can see here, patients who live in communities where the median income is less than $50,000 a year, they represent 25% of Massachusetts population, but 45% of all oral health ED visits in 2015. We scanned the literature and talked to providers and found that some reasons for that might be high clinical risk factors, in addition to barriers in accessing oral health care, including high out-of-pocket costs, and the fact that many dentists in Massachusetts do not accept mass health patients. We know that in 2014, only 35% of dentists treated a mass health patient, compared to 70% of primary care providers. So with that brief scan of avoidable ED visits, I will give you over to Rachel.
Before we move on from this one, I do want to mention that in the original brief on preventable oral health emergency department visits, we had identified an exemplar policy that has been adopted in Alaska, Minnesota, and Vermont around establishing a new level of dental professional that has additional training beyond that of a hygienist, is sometimes called a dental therapist, but that is not kind of the full education of a dentist. And in places where this profession has been introduced, they've been able to see greater access to oral health care visits, and these professionals are generally targeted and focused on the most vulnerable populations that otherwise do not have access to dental oral health care. And they have a more limited set of different services that they can provide consistent with their education and training. And would note for this committee's edification that Governor Baker did include language in his recent healthcare reform package that would provide that same level of licensure and training here in Massachusetts. So directly speaks to this issue in terms of being able to have greater access for oral health care.
It's in our purview to write to the legislature and urge them to adopt that.
We can certainly do that. I think we have made known to the legislature through some of these data findings where we have seen some significant concern around oral health care access.
Should we have a discussion in our board meetings about whether we should formulate it?
Sure.
I think that's actually should be. It should be for us.
We weighed in on the package, obviously,
Right.
but we'll see what happens with the package this week.
In the past, we've communicated to the legislature about allowing more non-physician personnel.
Absolutely. In the 2015 cost trends report, we actually made a very explicit recommendation that the legislature take action to remove inappropriate restrictions, specifically on advanced nurse practitioners, where Massachusetts is among the more restrictive states in the country in terms of the scope of work that they can operate without clinician supervision.
Did the government propose that as well?
He did, yes, that is also part of the healthcare reform package. So
We could weigh in on both of those issues.
I think
I haven't thought this through.
Yeah.
I'm just engaging in the conversation.
HPC has not, to my knowledge, made an explicit recommendation on the kind of dental therapists, we had identified it as kind of a model intervention. We had made that much more explicit recommendation in terms of the advanced nurse practitioners. And there are other professions that are also, I should note, included in the governor's package around removing restrictions on certain kind of clinical scope of practice in areas that the HPC has not generally examined, but include optometrists and podiatrists. You were right, Lauren?
The governor filed that whole reform package and asked the legislature to substitute that for the assessments under each of their budgets. We'll probably know in the next few days, right, what's going to happen with the package. And I would say, if these aren't in there, that we should revisit them and still be out there.
Okay, so I'm going to talk about our third data point, which is focused on contraception spending and utilization in the Commonwealth following the implementation of the Affordable Care Act. And as you probably know, the ACA included requirements for health plans to cover certain preventive services with no cost sharing or out-of-pocket contributions. And included in these preventive services were many contraceptive coverage benefits. These came into effect in August of 2012, so we're looking between 2011 and 2014 in our data. And our data point focuses specifically on pharmacy contraception, so prescription contraceptives like oral pills and patches and rings, and also IUDs or intrauterine devices, which involve a medical procedure. And what we found is that out-of-pocket spending declined both for prescription contraception and for IUDs. And this was driven by the majority of the decline was driven by the decrease in the number of women who had to pay anything out of pocket when they got these prescriptions or the IUDs. The graph on the left highlights prescription contraception. What you can see is 2% of the claims in 2011 had no cost sharing associated with them. And by 2014, 94% of the claims had no out-of-pocket contributions. The utilization was relatively constant during this time period with 1.2 million claims approximately each year. But that's not the full story. If we look at the graph on the right, which focuses on IUDs, we see that spending has a similar trend where 48% of women didn't have to pay anything out of pocket to get the IUD in 2011, but by 2014, 93% of women didn't have to pay anything. In contrast to prescription contraception, utilization, however, dramatically increased for IUDs. In 2011, under 15,000 women got IUDs, and by 2014, an additional over 18,000 women got IUDs. There are many reasons why this trend in increase in IUDs may have occurred, including increased clinical acceptance of IUDs for women who haven't yet given birth. However, regardless of exactly which factors contributed to this trend, this is positive for the Commonwealth. IUDs have a high upfront cost, but the literature finds that IUDs are cost-saving because they are substantially more effective, not only than no contraception, but then other hormonal contraceptive methods. So even women switching from the pill, for example, to the IUD results in increased effectiveness, and this is cost-saving for the Commonwealth. That's a great question. There is some literature, but because of the lag in data that we have, it's hard to tell. The decline in abortions and unwanted pregnancies has been happening for several decades, and so it's hard to parse out what exactly is due to the ACA, but as we get more data in further years following the implementation, we're looking forward to seeing what impact it has had.
Okay. All right. If there are no further questions, we'll move on to the CNS data section of this presentation. So this was very exciting for us when this data came out. Every 5 years, CMS, which produces the National Healthcare Expenditures, which we all know and love, the definitive source of data on national healthcare spending. They also produce state-level estimates, and they are only able to do this in 5-year chunks. So the latest data that we had up until a few weeks ago only went through 2009. And we made use of that data in the first cost trends report to compare us to the rest of the country. And this is really the best definitive source where we can make an apples-to-apples comparison of Massachusetts and other states in the country. Since then, we've been doing our best using CHIA's data on total healthcare expenditures to compare us to the national average. It's fairly close, but it's not quite apples to apples. So this is something we've been waiting for a while. And 2 weeks ago, they released the data up through 2014. So we explored that a bit, and we're presenting that here today. This data is based on Census Bureau data of surveys of providers plus administrative sources. And if you're curious, a little while ago, CHIA did produce a memo describing how THCE differed from this data. And again, it's fairly close, but it's not quite the same. So this is based on the personal healthcare spending totals that CMS produces. It's not exactly the same as national healthcare expenditure, NHE. It leaves out a few categories such as public health spending, research, and other infrastructure data. But this is pretty close to the NHE totals. Okay, so last we knew, we were the most expensive state in the country. Here we are showing that on the top graph, 2009, Massachusetts spending per person, and this is for all payers, Medicare, Medicaid, private sources, was $9,400 per person. And that was significantly above even the second highest state, which was Alaska at that time. It was actually 37% higher, well, higher than the national average. So now below, we have the exciting new data for 2014, showing that we are no longer the most expensive state in the country. Alaska has taken our place. And I'll show on the next slide, it's not just that they surged up and we stayed where we were. This is really a great, interesting finding. Here I'm showing the growth per year between 09 and 14. So starting with 09, the last data we had, go to 14, and what is the annual growth rate in healthcare spending? You can see Massachusetts far on the left, fourth lowest growth in spending per year, 2.3%, compared to the national average, which was just over 3%. Okay, only Arizona, North Carolina, and Hawaii grew more slowly than we did over this similar period. Yeah.
And looking at the data, I believe the data can be broken down by every time as well as every time. I think you can find that data provides very interesting data. When looking at every time, data things like drug coverage, as well as supplemental insurance policy, where Massachusetts stands in comparison to the rest of the nation. And then when you're just looking at treatment time, that changes as well. I think what you're showing is strictly treatment time. Is that correct, or is it all combined?
It is all combined. It's all
So this
combined.
is all combined.
Yeah,
I
yeah.
would break it down. I think you can find it's going to be pretty interesting.
That's a good point. And they don't break it down quite that way, but we can look by payer. And we don't have the by payer view in here, but we'll dig into that as much as we can in the coming weeks.
Can those of us on the side of the table note that in addition to poor eyesight, hearing is PH as well?
Yes.
And that there are ways to help us out.
There are.
Yeah.
Good point.
David, I thought the last time you did spending per capita in statewide comparison,
Mhm.
we were fifth. Were we showing us fifth most recently? And was that a different data set?
That was a different data set. I believe that was when we were showing premiums. Those were the private premiums. So this is really all in. So we didn't have to. Yeah.
Thanks.
Okay. This slide is showing the trend. So year-over-year growth. Massachusetts compared to the US. This is similar to a slide that we produced in the cost trends reports, but now we're having the best apples-to-apples comparison. And you can see that Massachusetts grew more quickly than the United States pretty much for the whole 2000 to 2009 period. And starting in 10, we've been, the line is below that orange line.
Maybe you can update this with our guests for Massachusetts.
We could attach on the 2015.
And we know, of course, with the US.
That's true. Yeah.
We also have guesses on what the US would be in 2016 data.
Yeah.
Right?
Yeah.
So we could do something
By
there.
the time the next cost trends hearing rolls around, we'll add 15 and 16 to this.
You know what else may help, David? when you break down the numbers and you look at the individual components, for example, I mentioned earlier was where do we stand with premiums, and when you add on pockets, what happens? Even just looking at out-of-pockets, when you compare the out-of-pocket trends in retirement in terms of cost to pre-retirement, there's a significant difference between the two. Having that level of data helps us focus on what we should be doing going forward. And if you can break it down that way, I think that could be extremely helpful.
I'm not sure we can in this data. I'll look again to see how they break it down, but I'm going to do some breakdowns by categories. So that will help us.
And I would just add to that, I think when we think about the presentation for their cost trends hearings, we've tended to have our own HPC kind of deep data presentation to kick that off. And we, I think we try to look at all of the different kind of component pieces, right? So this is healthcare spending. We'll look at premiums. We'll look at premiums for different types of populations. We'll look at out-of-pocket spending. And so I think all of those kind of add to the full picture of what's going on and break that out by different types of categories. I don't want to move too quickly past this slide because I do think that there's really some important findings here. Really, throughout the 2000s, the growth rate for Massachusetts was among the highest in the country. I think I had done the math from about 2004 to 2009, and we were about the 6th highest in terms of growth rate. And then from 2009 through 2014, as David mentioned, the 4th lowest. So this is a very significant reversal in terms of the trend in growth rates between really kind of an inflection point around 2010, with very significant growth before and much lower growth after. And I would note, obviously we always tack back to the 2012 healthcare cost containment law, but would also note for this committee that really the Commonwealth's efforts around healthcare cost containment were a series of pieces of legislation, including significant legislation in 2008 and in 2010, culminating in 2012. So there was a lot of legislative activity during that period of time focused on healthcare cost containment.
So I do love this chart, which is why I was thinking about it. But one of the things I think would be helpful to do if we could, David, is take a guess as to how much of the growth in 2006 and 2007 was because of increased coverage, and see if you can form an alternative line and how to take that out. And similarly, do the same for the national estimate in say 2014-15, and see if we can just take that part out, just so we can get a little bit closer to an apples-to-apples comparison. Because this chart is so stunning that it's something you really want to look at more. And I also agree with the idea of doing this by premiums and stuff. And also, if I recall, where we were particularly off the nation was in LTSS services for the Medicaid population. And so the more we can break this down by different populations and different types of services, so for example, we could form an acute care trend now given those data, and I think that would also be interesting. Look at again, taking out as best we can the coverage, and we can certainly do that in various ways and stuff like that. But I think getting a whole handle on these would be really fascinating.
Yeah, those are good suggestions. And we do a little bit of that in this presentation with see the home health stuff on here. And just as a rough guess, most estimates of the effect of the coverage expansions on increased spending are kind of in the 1-3% range. So I don't think it's all that, but
No, it's really not all that,
we
but
can
I
shave
think it would just be nice to shave off the little.
I agree. I think it will shave off that.
Yeah, exactly.
So in the next slide, we're breaking down to the two biggest sectors, hospital and physician. On the top, you see hospital spending per person in Massachusetts and in the U.S. Massachusetts is the higher one on top. And in 2000, you can see the difference there. And then by 2009, hospital spending in Massachusetts was quite a bit over the U.S. average, having grown 7.6% per year. That's what that orange dotted number means, annual growth, compared to 6.3. So we grew faster. We had this huge gap of $1,100 per person in the hospital. And then from 9 to 14, you can see that our hospital spending grew at less than half of the U.S. rate, 1.8% per year. So that gap really closed quite a bit. And in the below graph, in the physician spending world, it's a similar story. We grew faster from 2000 to 09, and then we grew slower. So that gap closed a bit there too. But the hospital was the more dramatic story.
What did you find is the biggest cause of the decrease?
It's probably that, it's the hospital spending. And you'll see again another view of that. Yeah. Okay, so two more. This one is showing the percentage by which our spending is higher than the US, so on a percentage basis. And you can see again in hospital spending, in 2009, we were 42% above the US average. By 2014, that dropped to 28% above. Okay. In physician, we were 24% above, and then 21. And then you can't help but miss that home health gap, where the few cases where our gap with the US grew quite a bit. And we talked about that in the cost trends, and we know a bit about that. And I think since 2014, there have been efforts to look at that more closely. Nursing care facilities, the gap shrunk. In drugs, the gap grew a bit again, and then the other categories are smaller. So on the far right of this page, you can see that overall, we were 37% above the US average in 09, and that reduced to 31% above. And then comparisons with the rest of New England, even that has shrunk a bit as well. We were 6% older and now 4%. Yeah.
So can I just want to understand the home health for 1 second. So we've spoken about it in terms of our additional spend on OTSS services in the Medicaid population. A lot of this is the Medicare population.
Yeah,
And
they're both in there.
when I look at this, what I'm thinking about is the ACA cuts on the home health, and which I think were largely they were for Medicare, and I think what that did was it reduced a lot of home health services in places like Florida, Louisiana, and down to the south, where home health was extremely high and believed to be actually quite fraudulent in a lot of those areas. And so I'm wondering how much of this particular chart is a reduction from those super high levels in some of those other states, and how much is a relative expansion of LTSS services through the Medicaid population here, which we have discussed before. I don't know, one way to look at this might be to try and compare Massachusetts with other rich non-southern states, again, because of that issue of the extremely high use of home health care services in, say, Florida, down through the Mississippi Delta. But maybe if we took New York and Pennsylvania and California or something like that and tried to form another rich state average,
Yeah.
I don't know if that would be different from some of this. They also would have some of this by payer, so we could potentially back out.
Yes, and split this up.
How much of this was the Medicare? Because the ACA did a number on the health stuff. I think it was with the hospitals. I think they both took some. I can't remember if it was the ACA or it was just before that, but there was something about the home health.
Okay.
One thing to consider, the 155 number may be actually a positive. You may be referring to that. And that may have helped cause a decline in the slope. Let's face it, the more home health care you have, the less nursing home, you have other issues, emergency room visits and things of that nature. So it'd be interesting to see how those numbers fit.
That's a good point. That's a good point. I wish I could really tease out the causality there.
I want to emphasize that as well. I don't think we're wording to put a value proposition necessarily on some of this, and where we see that we kind of narrowed the gap between us and the United States in nursing care facilities. Some of that increased home health may have helped contribute towards that. So I think it is worth kind of understanding it a bit more and knowing are we getting value for that additional spending in the home health area. And I would note on the Medicaid side, where it's been well documented that there has been some significant increases on the home health spending. This administration put in place a number of different policies and procedures to try to understand and control that spending increase on the Medicaid side and make sure that was going for legitimate services for the members that rely on it. And that was after essentially this data came out.
Yeah, just to say, it seems like reinforcement of the state is an area that continues to pop up every time we have these conversations and review these reports. Clearly was identified at our in meetings and hearings around setting the agenda for the next year of the HPC. So it seems like, again, this is another, we have to dig in deeper to this, not to go into the next conversation. I know there's a lot still coming. It seems this could be a good area to focus on for cost trends hearing as well. We see this as a big area of spending that we don't necessarily know if it's good, bad, whatever it is, but warrants a lot more conversation on. Yeah.
Oh, yes, please.
Here, and I think this might be getting at not drawing a correlation, but I wonder what's the cost differential between the 60% increase in home health spending and the 14% decrease in hospital spending.
Right.
You know, and you're not correlating cause and effect, but you're looking at the weights of the buckets.
Yeah, there could be some trade-offs there. Okay, great. So one more slide. So again, this view is by percentage differences, but it's sort of masking, well, what are the big categories and what are the small ones? So the next view is similar, but let's look at the dollars. Where are the dollars going in our excess spending above the US average? So here you can see that in terms of hospital care, and we used to spend $1,000 more on hospital care per person. And now that difference has reduced in dollar cents to about $850, okay? And on the bottom in the gray, it shows, well, let's take our total dollar difference with the US and figure out what percent of it is explained by each of these categories. Hospital care used to explain 42% of our gap, and now it only explains about a third. So where's the rest of it coming from? The next group is the long-term care and home health, so they're combined there. It would be interesting to split that out as well, but when they're combined, this is a growing area of explaining our difference between us and the US. Now it accounts for 38% of the difference, more than hospital care. Professional, the dollar difference has stayed the same, and that explains again the same amount of the gap as well. Drugs now explain 5% of our gap with the US. It used to be 3%. So just a different window on the same thing. Okay. So I think I don't need to go over the key findings here, but there's a lot more to dig into, and I appreciate the comments.
Great. Seeing no other comments on that, I think, as David mentioned, we'll continue to dive into that data. I think we have a couple of different number of ways to cut that, and I think that will be a part of our planned presentation for the cost trends hearings itself is continuing to look through that data. And again, I guess I would highlight both that this is, I think, demonstrates some progress that Massachusetts has made in terms of healthcare cost containment, but not overstate the fact that we're still number 2 at 31% greater per capita spend than the national average, and that there are significant, as we've noted in past reports, affordability challenges that remain. So put this in context of all the other data, and especially in some of the data that we know after 2014, where we've seen through the Division of Insurance significant double-digit increases in some of the premiums in the fully insured market. So remember that context as we look at this. So moving on to the next conversation, again, as I mentioned, was hoping to just tee up and hear from the committee members around some of the areas that they're interested in for the cost trends hearings, any feedback from kind of the past hearings. This is our 5th cost trends hearing at the HPC, and I've included on this slide, which is slide 25, a couple of the goals and purposes that I think of when I think of the cost trends hearings and how we built them over the last 5 years. Enhancing the public transparency and accountability, engaging with national speakers and market participants, our state government leaders, using this as a way to evaluate the different market participants' efforts to meet the healthcare cost growth benchmark and engage in direct questioning with them, having kind of a public record, both written and oral, around these efforts, and engaging the public really in the work of the HPC, the mission of the HPC, and we have a broad public outreach aspect to the cost trends hearings. So some potential modifications that we've been thinking about for conducting the hearings this year. We have tended to do these in 2 full days. It's a long 2 full days, packed full of information and witnesses. And so I think we're proposing to do a little bit of streamlining this year and bring the hearings down to about a day and a half. And so that we would potentially end the second day around lunchtime and kind of focus our time together a little bit more. This would probably allow for 4 to 5 witness panels over those 2 days. Potentially proposing to reduce the number of witnesses on the panels. We've had in some years up to 6 different witnesses on a particular witness panel. I think the reflection that I have is that we can ask 2 or 3 questions and basically use up all of our time as 6 different people provide their perspectives on that. So proposing maybe to do a little bit more, again, focusing 3 to 4 witnesses per panel, allowing for a little bit more of the time for an in-depth examination. And then I've included here at the bottom of the page some potential themes that have come out both through discussions that we've had at the committees and at the commission level. I think the benchmark hearing process that we engaged in earlier this year highlighted a number of different opportunities that we may want to follow up on. And I think would note specifically where the commission has had an interest in revisiting past market transactions that have occurred in Massachusetts and examining witnesses around, well, what happened after you merged or consolidated? What has that meant in terms of healthcare spending trends or access? Did you accomplish the goals that you set out to accomplish in terms of some of these market transactions? So here too, where we've had a little bit more years of data, we'll actually have objective information to go back and look at some of these past transactions and have some information to be able to put into the public sphere and also to be able to question witnesses on that objective data. So with that and broad overview, I think want to hear from all of the commissioners around the areas that they're interested in, if they have particular ideas or suggestions about how to conduct the hearings. If there were things that you thought worked particularly well in the last couple of years, interested in that as well. So start with you, Professor Cutler.
So this is very helpful for talk. I agree on the streamlining because I think that we've been unable to hit on all the issues that we really wanted to, and I think it's important that we be able to do so. It strikes me that there are basically 3 topics here, and I agree with all 3, and so but 3 may be too many for us to explore with the House Plans hearings. But one is kind of areas where we believe there's significant savings to be had consistent with improving population health. In the past, we focused a lot on behavioral health issues, and I think that cut here, which is probably right, is more on the use of particular services regardless of the population that we think may be overused, whether it's institutionalized care or higher cost settings of teaching at academic institutions compared to community hospitals. So I think going back over that and seeing how that, what kind of progress we're making on that is the and what more could be done is the first area. I think that ties into the second area, which is I really would love us to go back and to do a retrospective on consolidations, both that we've approved and potentially before us, that promised savings on the front, particularly on the front of shifting people to lower cost settings. And we've highlighted some successes in the past, and we should highlight the ones that have not been as successful. And we should give people a chance to respond to that and to say, yes, it wasn't as successful as we thought, but here's what we're doing. We think it was more successful, but not showing up in the data or something like that. And then the third area is the one that you have under advancing value-based payment reform, but I think it's probably a little bit broader than that because it has to do with uniform assessments of quality, data flows, and everything at the level of what can we do to make the healthcare system both cheaper and to work smoother. And so part of that is payment reform, particularly at the episode level rather than at the patient level, because there's already paramount at the patient level. But again, all the things that we've had on the state quality process, and where we are with that, and what are the big priorities there, and information flows that have been haphazard, and where we are. And so sort of dealing with that package as a whole and saying where is the state on that relative to where we and others in the past have thought. And I suspect if the first couple are blaming others, I think this is probably a little bit more blaming ourselves as a state for not having done everything that we ought to have done, and maybe a chance to be clearer about what we would like to see going forward.
So a couple of reactions, thank you. One, I think behavioral health is truly integrated into all of these topics, and certainly when we think about efforts to reduce readmissions, we know that many of those patients who are being readmitted to hospitals have behavioral health comorbidities and conditions, and so enhancing the care for patients with behavioral health needs or other social health needs is key to being able to shift some of these different trends. But as you know, we're kind of focusing on the ultimate outcome, which is reducing inappropriate utilization of some of these high-cost settings. Secondly, on kind of the retrospective ability to look at transactions, you noted that we did do a little bit of that last year with the Leahy-Winchester transaction. And we'll have, again, more updated information. And we'll be able to look at transactions that even predated the establishment of the HPC. There were a few that happened kind of in the 2010 to 2012 time period where we're going to have some run out now of data to be able to examine and look at those. Again, both not just to highlight failures or blame certain transactions, but really also to learn from where they have worked well, what has been the thing that they've been able to be successful in. And then I think on your last point around value-based payment reform, I think I would probably, if I did the slide over again, kind of add in advancing more effective value-based payment reform, because I truly think part of our focus here is we know that we need to move away from the fee-for-service model to be able to support providers in doing all of this work. But we also know that that's not in and of itself enough, and that the efforts around quality of measurement alignment and being able to have interoperable flows of data, we hear all the time from providers is extremely important for them to be able to meet the goals as presented. So just a couple of reaction points, but interested in hearing from others.
So I agree with everything that's been said, and I also the Winchester Leahy findings last year were really interesting, but I do think we spent a lot of time looking at transactions in the marketplace, and so doing that again I think is very important. And I would hope that we would have an employer panel again. I think everybody agreed it was very interesting to hear from employers, since they, people who work, they're the primary source of their health insurance, and the challenges and the strategies and things that they're doing, I think was really helpful. And I would just offer, if we're going to do that, I know last year we were trying to get a couple of additional ones. We need to begin to put those on their calendars early, and happy to help you identify some and then do some outreach. So just make that happen.
Thank you. You've always been helpful every year on this particular topic. I agree. I thought the employer panel last year was a great contribution. I think both in terms of really putting a human face to the challenges of healthcare cost containment and affordability challenges. and as well as thinking about what are strategies that employers can deploy to really engage in these efforts as well. So I think there's both elements to that.
Once Rick talked about having business leaders, I was thinking about how to have the frontline caregivers, or how some of these strategies are used around avoidable PD readmissions, and what are employers, hospitals, and others doing with their workforce to address these issues. I bring it up every time we have presentations on the chart grants in particular and how they engage their workforce in that. And I think there's other strategies and programs out there that might be good to highlight around how to engage frontline caregivers in trying to address some of these issues, and knowing that's part of their job to help reduce the overall cost of healthcare. The Commonwealth, there could be an interesting panel or discussion to have within many of these categories. And just in my head, I guess it's just where we're at with our politics these days. It's what's the environment going to be around healthcare when we're having this discussion? What's the impact of the federal conversation around the ACA? What does that mean for our state? What role does the HPC have in those conversations? Like, no one can predict what it's going to look like, or what the environment again in which we're going to be having the cost trends hearing. But I think it's something that we should keep in our minds if we're thinking about this hearing about what's going to be happening in the state of healthcare around the country and in our state. I think that would be something we should take into consideration. And I noticed in one of the hearing last time was my first meeting at the HPC, so it'd be a good anniversary for me. But one of my highlights in my brain was the conversation with the pharmaceutical industry, and how entertaining that conversation was, and figuring out where does that fit again in here. Clearly an issue that was addressed at the last hearing, we continue to focus on, and how does that fit into this overall issue. And I think maybe a little bit early, but again in the context of what's happening with healthcare in the country and our state, about our waiver and some of the district dollars, how's that being spent, how's that impacting some of these things. Again, maybe a little early to have some of that, but that could be an interesting conversation to try to weave in as well, just being relevant to the environment in which this conversation and hearing would be happening.
Great, thank you, Commissioner, and certainly I think we are challenged, as many other organizations who are planning healthcare conferences in the future, in terms of trying to predict and understand what that context will be. And I think another piece of kind of contextual information that we don't know today, but I think will inform the hearings as well, is what was our performance against the benchmark, and where we'll have data and information from CHIA in September about did we exceed the benchmark again? If we did, what were some of the main drivers of that? And that may inform where we want to focus some of our energy as well.
Two things to add. In the spirit of doing a retrospective look back, I think often we've brought organizations that say haven't met the benchmark, and the questions have been directed at what could you do better, what didn't work. But I think that hearing from organizations that have actually succeeded in hitting the benchmark or employed strategies that have really driven down costs would be interesting to hear from. I think it's often we look the other way, go the other end of the spectrum, but seeing the successes would be an important way to learn from providers, plans, employers, to hear what's working for them, and so that we can take ways. The other thing I would add is focusing energy on defined policy recommendations that the board can kind of endorse for the legislature or the administration to consider for the legislative session. There's a lot of issues out there, price variation, the tiering of networks, and I think it would be helpful to bring those conversations to the forefront at the hearings, and with the objective of getting defined concrete policy recommendations from the Commission.
Great, thank you.
I think we covered most of it, but just to bring up a couple of points, and just to emphasize a few points that were brought up earlier, looking at the whole farmer issue. If we look at that cost today, it makes up around 15% of what we spend in healthcare. Given current trends, it's going to be around 27% in around 10 years. It's a really important issue. Now, how much can the state do about it? That I don't know. But the point is, it is a critical issue. And when we're looking at I think it's important, shifting community appropriate care, right? I believe the key to shifting care is literally innovation. Or you're gonna have people like me, I don't wanna go to the community hospital. I don't believe it's at the same level of quality. Now, that may not be, we have data that shows that's absolutely not true, right? But the point is, it's all image. And unless they come up with innovative ways to compete, that isn't gonna happen. And I think it's really important that we look at innovation. And lastly, when we talk about policies, over the last 2 hearings that we've had, we've talked about transparency. But the reality is, very little has been done in transparency. And if we have 20+% of the population on high deductible plans, cost becomes important because it's not the quote insurance company paying the bill. We are paying those bills. But if we don't know what those costs are, I think that's a critical issue in terms of coming up with a policy recommendation that we should look at. We do have laws on the book, but the fact of the matter is it's not working. And what can we do?
I think that's a great point, and certainly wanted to highlight, Commissioner Foley mentioned kind of the national context. I think there's also the state context, as Lauren mentioned, in terms of what are some of the reforms we could do here locally. And also, Commissioner, to your point, at the same time this fall, the state is going to be launching a new transparency website. The Center for Health Information Analysis is planning a launch pretty much around the same time as the hearing. So that will be another kind of public-facing thing about how can we use this tool, this new tool that the state will have in order to be able to help accomplish some of our goals. So I think another area for continued conversation. So with that, thank you. This was a lot of good feedback on the cost trends hearing. There's more to come, obviously, on this as we continue to plan. So we're going to move on to the second part of today's meeting.
Just one, I know you said we wanted to streamline the speakers and so on, but one thought occurred to me on the comments of my colleagues. Andy Slavitt, the former head of CMS, he's become very, very outspoken on healthcare things. And, I know a little bit
Great, and we haven't, I think, identified a national kind of speaker for that slot, so if there are other ideas from anyone, please let us know. Okay, great. So I'm going to call up Griffin Jones here, who is our senior manager for the healthcare innovation. Speaking of innovation, our healthcare innovation investment program, as well as members from Boston Healthcare for the Homeless, to talk about some of this work. So, good morning.
Thank you, David. Good morning, commissioners. In my capacity to introduce one of our intrepid HCII award teams, the Boston Healthcare for the Homeless program. You'll live up to it, I know. Allow me to provide a little bit of context briefly, but then turn right over so that we can hear about this exceptional initiative and the work they're doing and allow you to ask plenty of questions. So recall that nearly a year ago now, the board voted to make $11.3 million in awards, investing in innovative projects that try to advance healthcare quality for lower costs. The Healthcare Innovation Investment Program, you may remember, is composed of 3 separate pathways. The latter 2 are investing in telemedicine and standardized protocols for treating substance-exposed newborns and their mothers with evidence-based therapies. So investing in solutions, whereas the former and the topic of our awardees today is the targeted cost challenge investments, where we asserted 8 challenge areas, cost drivers for the state, and welcomed the best, most innovative evidence-based solutions to be brought forward and invest in them. And the Boston Healthcare for the Homeless program is one of those 10 awards and one of the best illustrations of the kind of work that we had hoped for when we designed the program and are doing work in serving patients today. I'm pleased to take today's opportunity as the first business day in July to mark this as a milestone. All 20 initiatives are now launched in serving patients, including Boston Healthcare for the Homeless program. So I'm excited for you to hear more. On the next slide, where all of the targeted cost challenge investments emphasize partnership and scalability to unstick, we thought, statewide healthcare challenges that are ripe for innovation. Boston Healthcare for the Homeless is an exceptional example of this, precisely that type of innovation. And as we reflected on the suite of 10 awardees for the TCCI challenge, while all of our awardees are implementing innovative and difficult initiatives in order to target healthcare cost drivers, and all of them as a requirement for success, and as we see in improvement science, require organizational involvement and executive commitment to these things in order to achieve the goals that they set for themselves. Boston Healthcare for the Homeless program stands out as exceptional. The degree to which this innovation, this initiative is part of their larger and much longer term transformation to serve their patients is indeed, I think, worthy of this time and hopefully plenty of questions. Because I may caution you that this team will make what they're doing look simple and obvious, but it is far from that. And while all of the TCCI, the 10 TCCI investments are evidence-based, that was a prerequisite of being funded, there's hardly the kind of playbook that one would need in order to implement these initiatives very simply. Part of our capacity at the HPC is to learn from what they're doing and to build that, hopefully, for the next person to take it on. But the disparate structures that Barry and Mary are trying to pull together is, I believe, nation-leading and very exciting work. So with that, let me turn it over to you both to please explain your work and describe your exception.
Thank you, Griffin, and thank you for having us here today. And so I'm Barry Bach. I'm the CEO of Boston Healthcare for the Homeless program.
And hi, I'm Mary Takehead, I'm Senior Health Policy Advisor.
And Griffin, thank you for that introduction. It was very sweet. And everything we do is really simple, so it should be easy to follow. So first of all, I really do want to thank you all for having us here today and for funding this initiative. And just if you can tolerate for a moment, I want to do a little bit of background on our program, and then move into Mary will really talk about this project specifically. So, as you may know, we're a private nonprofit. We've been in existence since 1985 with a fairly simple mission statement where we're trying to provide and ensure access to quality health care for all homeless individuals and families in the greater Boston area. And we practice in 45 different sites across Boston. So a lot of the shelters, domestic violence program, soup kitchens, as well as on the streets of Boston. As a program, we also have 124 respite beds, which are essentially hospital step-down beds. And we own a pharmacy and have a very large practice that's really devoted to primary care, mental health services, and addiction services. And we have a number of innovations that we're happy to talk about with that. Part of why this grant was so important to us is because of how complex the patients are that we get to care for. And so what you see up on the screen now is just kind of a brief snapshot. Monica Burrell, prior to being at DPH, was our Chief Medical Officer. Monica did this study that was published in the American Journal of Public Health. And it was our first time as a program being able to really look at mass health data. So we, as most programs, and one of the wonderful things that's happening in terms of transformation in the state is being able to actually see data for the patients that we care for. And you can see the high burden of illness. This was looking at 6,500 patients, and you can see that almost 70% of patients had a diagnosis, and this is based on claims data. 68% of patients had diagnosis of mental illness, 60% of substance use disorder, and you can see one thing that really stands out just to point out is, and we know the high cost and the high success of treating patients with hepatitis C, you can see that the prevalence is 23% in our patient population. In the general population in the US, that's roughly about 1 to 2%. And then if you just drop down to the second part of this page, you can see that roughly our patients are 3.5 to 4 times the cost and utilize the system roughly 4 times as much as the general mass health population. And please, I'm sure you will, but please feel free to interrupt and ask questions. So about 4 years ago, we came up with an idea. We knew that ACOs were on the horizon, and a lot of our community partners, and I use that as literally partners in our community, not as in behavioral health community partners, so not to be confusing. But we realized we weren't providing a system of care for our patients. And frankly, I believe that in terms of healthcare, that there's not a true system of care. That's certainly true in terms of homeless services. And so we came together and said, is there a way for us to be able to be thinking about our patients so that we're providing single points of access to care, and that there's coordination so that Boston Medical Center or MGH, where a lot of our patients go, will get wonderful care for their congestive heart failure, but once they're discharged back into the community, what can we do to help improve overall health care? How do we help decrease costs? How do we improve the patient's lives? And sort of looking essentially at the triple aim, recognizing that that really happens in the community, that doesn't happen at the hospital level. And the fantasy that we were operating under was at some point we may be able to tap into some ACO dollars. We didn't understand district at the time, but that there may be some money coming together. So that drew these partners that you can see, which are the largest service providers for individuals experiencing homelessness in actually Massachusetts, but certainly in the Boston area. And what helped galvanize us as a group was after about 2.5 to 3 years of coming together, learning about how ACOs operate, learning about financing, understanding some of the utilization patterns of our patients, was that we received some funding through EOHHS, through infrastructure capacity building, and that really helped us come together and begin to really act as a catalyst.
Yeah, so the ICB grant, which is Infrastructure and Capacity Building grant that we received from EOHHS, really allowed us to cement these relationships that we have with our partners. It allowed us to basically hire lawyers to form an organized healthcare arrangement. So this is a legal agreement that begins to bind our organizations and allow us to begin to share information. That was huge. To be able to share certain amounts of protected health information with shelter providers, behavioral health providers, in order that we can work on goals that we agree are important. And it also began to formalize our governance processes. It gave us ways to approach voting and membership, and it also, by having this OCA agreement, it also allowed us to begin to think about how we might be able to work with the city of Boston in its Continuum of Care initiative. And that was probably one of the more surprising and wonderful aspects of our consortium work, is that the city of Boston reached out to us, knowing that we had this consortium in place, knowing that we're looking to share information, and wanted to know how they could work with us. They had data in place, and now that they knew
that we could begin to share data in a secure way? How can we work and collaborate to end chronic homelessness in Boston and work on the mayor's initiative? So it seemed like a good idea for us to move forward with this. And by having this, the ICB grant funding really allowed us to kind of get our act together to first to be able to bid on this Health Policy Commission proposal. And then from the Health Policy Commission proposal, it allowed us to think about what we might look like as a mass health behavioral health community partner. So that ICB grant was really was a catalyst for us to get this in motion, and then the HPC grant really allowed us to visualize what our partnerships would look like. So here's our Health Policy Commission grant. We called it Social Determinants of Health Coordinated Care Hub for Homeless Adults. And what our whole premise is that we are looking to reduce unnecessary utilization for the highest cost mass health homeless people in Boston. So we looked at mass health claims data, we took the top 10% highest cost patients, and then we did further cuts to look at those that had high utilization, those that are using the emergency department more than 6 times in 6 months, or using the hospital more than twice 2 admissions in 6 months. That's the patterns we were looking to change. We weren't looking to change utilization that was necessary, like say for cancer treatment or follow-up after trauma. We were looking to impact things that we thought that were primary care, and addressing social determinants of health had opportunities for improvement. So how are we spending your money? We have a $750,000 grant for over 2 years, and we're passing through most of the money to our partners. We are providing case management at our, I'll call them social determinants of health partner organizations. So we're giving them a payment. It's $3:25 p.m. and it's based on a.
We had recommended that to Dan's side, but somehow he missed that one. So.
It supports a caseload of 15 to 1, and that seemed to be a kind of number that we were seeing in other kinds of pilots and case management initiatives across the country for very intensive patients. So they have a 15 to 1 caseload. We flow that money out to the organizations, and then we also offer an additional incentive for our partner organizations for $10,000 for them to come to the table every month and to do the administrative work that's going to be asked of them to comply with the terms of this grant. We also have funding, as you can see, for some of our administrative support, including data analysts and an RN navigator to kind of, I call HERD, our case managers that are now out based in partner organizations that we don't employ. These are case managers that are partners.
And I think it's just important to note that when we talk about case management, we're really talking about face-to-face encounters. So I know that just having talked to a number of folks about what they'll be doing around behavioral health community partners, which this really laid the foundation for us, we're really talking about face-to-face encounters. The fact that we have clinics in most of the large adult shelters, and as I said, and on the streets, we're able to actually coordinate with shelter-based staff as well as our own staff. And so we're able to do one-on-one encounters that are face-to-face, which is fairly unique at this moment.
This slide we developed for our partner organizations to try to explain the project to our case managers, and I'm going to use this as the framework for how we're going to discuss the project with you. But I think what's important to acknowledge is what a huge culture shift this is for our partner organizations, for them to think about first this intensive focus on patients, small amount of patients, but really the big shift is access to data. And what do you do with that data, and how do you use it to change care?
Right. I also want to mention, just to Mary's first point there, that if you're, the staff of the Pine Street Inn or the staff of even organizations like Baco Human Services, they're not necessarily thinking about medical care. So, and their primary focus, especially for the shelter-based organizations, should be on housing. So that is where they're spending their energy and their time. We were trying to say to them, we need to change that mindset. We need you to start thinking about healthcare. We want you to help bring patients into the clinic. We want you to help find patients for us so that they can have that follow-up. So they had a psychiatric admission, they were in the hospital for 5 days, they're now back in the shelter. Let's get them back in to see a psychiatrist or a therapist as quickly as possible. So we were trying to help change mindset for them as well. So it's a huge, and has been and will continue to be a large cultural shift.
And as Barry explained earlier, you saw how complex our patients are. We think we're doing a pretty good job of providing primary care within our buildings, but as soon as they leave our clinic, things start to fall apart. So it's this whole idea of how can we extend our team to have more of an integrated team, and what does that look like? So this is the way we'll kind of unfold it to you. So as I had mentioned, we provide a 3:25 p.m. to support a 15-to-1 client ratio. We took that first cut of the list where our target population is 60 patients under this grant, and so we had 140 patients that met that first cut. And then we shared this list with our organizations, partner organizations, because now we have the privacy insurance through that OCA arrangement. And we basically tried to assign these patients to organizations that already had existing relationships, so we can get a head start. We don't want to be introducing new people necessarily into some of these folks' lives. If we could already build on existing relationships. So our organizations raise their hands like, oh yeah, he comes to our clinic, or she is receiving mental health care, and so we began with that. And then we, again, just for a little extra insurance that we are protecting patients' protected health information, we did ask clients to consent for participation. They have to opt in. All right, so as I had mentioned, the information technology is really a uniter for us. This is what's linking our information. The City of Boston has provided us with a platform to do this. I'm learning so much about IT now, it's scary. There's a window or a cloud that is, but it has new uses now. That's where it hosts all this data. The data gets pushed up to the cloud, and this is where the City of Boston's housing data is. The thing is, the City of Boston had all this housing data, but they weren't sharing it with, outside of the city. So now they're sharing it with all of us, so that we can go into this cloud and see where did the patient sleep last night. Oh, he slept at the Pine Street Inn. I think I'll go there to find them, or find out other good data about our patients. So this information is up in the cloud, can be accessed by our case managers, and we have a special window into the cloud that limits access to this data, because it's also pulling information from our electronic health record, so that we have now a window that only our organizations can access. Data comes into it every day that's refreshed from our electronic health record, as well as from the City of Boston's HMIS system. The city also provided care management software to all of the organizations that are in our pilot. And within this care management software, there was also this assessment that I'd like to show you. It's called the Arizona Self-Sufficiency Matrix. This was something that one of our partners was using, really small type, but it's more of a placeholder just to show you something we're really excited about, is that we are now going to be systematically measuring with our partners how self-sufficient our patients are doing and how our interventions might be improving their self-sufficiency over the course of the pilot. There are 19 domains that are graded from 1 to 5 that we will be doing on intake, and then every 6 months along the way to make sure that we are actually moving people along the scale. So you can see the kinds of domains from housing to adult education to legal and mobility issues. And so this is a way to score and for our case managers to know whether or not their interventions are actually working. Pretty excited about that. We also are using the shared care plan. This is new for our organization as well. We have this integrated care plan that lives up in this cloud, in the data platform. And this is a live document that any member of the care management team can edit. So it is to invite collaboration, and we are, the care plan is going to be developed during a case conference. We hope the patient attends, and that case managers from the field will be attending with our medical home teams. And of course, the goals for the care plans are informed by patient priorities, or things that are important to the patient. I just wanted, this is a screenshot of a fake patient, but it is actually a live, this is what our system looks like now. It's evolving, we're improving it along the way, but as you can see from this document that lives up in the cloud, you will have team members that you can click on and see who the doctor is, gotta have an email from the doctor, know who's the case manager, where's the email, and how, so that people can get communications, and that when changes happen to the care plan, members of those care teams get dinged, they get, or an update has been happened to the care plan, so they'll get some notifications. Team goals, we have 4 team goals. Housing's number 1. If a patient is not housed, getting them into housing is our priority. If they are housed, having them maintain housing is our priority. We're going to also have medical or SUD kinds of goals if appropriate, and then there are self-management goals. What are some of the things that the patient thinks that they can work on to improve what's important to them? This is an example of the kind of data that case managers will now have at their fingertips. What we're really excited about is that it'll show upcoming appointments. For instance, one of our pilot patients right now has an appointment at our clinic tomorrow, so that there's notification, you will have an appointment, so please accompany that patient to the appointment. It's really important that she gets there. They're also going to have a limited access to a problem list. It's not going to be the whole laundry list of problems, but the kind of the top diagnoses and then medications. We're looking for the case managers to help us with medication adherence, making sure that patients are filling their scripts and are taking their meds. It's important to know if they're on insulin and other things. The primary care team connection is, again, one of the things we're excited about. We have now new tentacles into the community, and we have a way to contact the case managers so that they're communicating and working towards common goals. We have an RN navigator that we hired with this project, and she holds weekly meetings with the case managers to talk about who have they enrolled, have they, are they making some of their target metrics, and what kinds of needs do they have. Yep. Sure. And then you can see we have a whole host of data which we can go over later. Here is the kind of data that we are collecting. The information on the left is kind of the usual suspects, claims data and EHR data. On the right is pretty new stuff for us. We're really looking to measure what we're doing and what we're connecting, how we're connecting folks to case managers and care. And then continued support from our leadership team. So we're pretty excited as where where we are today. The pilot began with enrollment in June. We've got 12 patients enrolled by now, so we're a fifth of the way there. We're flowing out payments to our case management organizations. Weekly case conferences began 2 weeks ago. We have that data platform is beginning to get phased in. What we're really excited too is that we have a consumer advisory board that we launched. We have 5 consumers that are on that board and have been actively helping us think about new ways to change the care plan. You know, think about the job description for the case managers. They've been wonderful. We have 2 grants that have kind of come in addition to the HPC to help us with our project. Funds from the Harvard School of Public Health, boots on the ground to help us with the curriculum with our case managers and a texting study so we can get pilot phones out to some of our pilot patients. And then what we're really excited about is, I alluded to earlier, is that this Health Policy Commission grant really helped us lay the platform for our sustainability plan, which is the Behavioral Health Community Partners. Our RFR that we submitted in May is basically this entire grant, scaling it. So we're excited about that. We have challenges already. We have 3 partners that declined to provide case management for now. The numbers were kind of small for them to do that, but you know, they're still participating in the monthly meetings. You know, we're always finding patients is always a challenge, but we're out there. Hiring staff, we've had some problems with that, and the challenge is that only part of the data platform is phased in. It's more complicated as always. And I kind of want to just to end on you know, what this pilot has done for us, and it's allowed us to think about ways to integrate our system in ways that haven't really been done before in other parts of the country. There are a lot of complex care management projects out there. There are hundreds of them, but it's really hard to find one that helps just on homeless populations. And so it's really helping us think about what are the gaps and how we need to really rethink about how we define partnerships and work with our community-based organizations. And it also allowed us to, as I mentioned, leverage what's out there. The city of Boston was what was out there, and to be able to kind of jump on their data system and leverage that, I mean, that was no cost to us in the sense that they had created a lot of that infrastructure. We are going, if we're successful in the Mass Behavioral Health Community Partners, we'll go from 60 to 1,000 in less than a year. That is exciting and frightening all at the same time, but we're really enthusiastic about what that might mean for our program. And we, again, I want to echo Barry's thankfulness for making this grant available and helping us get our wheels turning in this initiative.
And in the course of turning it back over to David and all of you for questions, let me also again promote Barry and Mary in that I think I know what you're thinking. Wow, this didn't seem simple, and yet as complex as it does seem, there are so many layers beyond this that are that I was able to witness during attending some of the meetings and just checking in on you know, the overall progress of your initiative. As illustrated, probably no more in a meeting where amongst the IT representatives of your various consortium members who you know, you would have thought we could come to a consensus on HUD data, on how do we measure housing. Everyone uses it, you have to report it. But for as many members as there were that many ways of interpreting it differently and measuring it differently. So I would assert, and for you know, commissioners' questions and probing, that the innovation here that we appreciate so much about your initiative isn't the cloud, and it's not an app or some other kind of single technological breakthrough. It is that integration that you mentioned at the end, Mary, and where so much of your work has been invested, but so much of the transformation that I've witnessed occur just in the preparation period, and I'm excited to see this in implementation.
So thank you both for the presentation. I want to highlight one thing that came through in the presentation is really this phased approach and this kind of warm handoff with Mass Health and UHHS. It really was their initial grant that helped create this consortium. We are providing a grant to actually launch it and get it out the door, seeing patients, and as mentioned, if successful in the Mass Health program, we'll see that scale and expand. So it really became a great opportunity for some sequencing, all building towards our shared goals with Mass Health in terms of reducing some of this utilization and really focusing on a very complex patient population. A question for both of you. It certainly came through a lot here how difficult it is to be able to share data and information across different organizations. I wonder if you could just speak for a moment about having kind of broken through some of those barriers. What has been the reaction from some of the other consortium members who are seeing some of this data and kind of care management information for the first time and being asked to act on it?
So I'll start. So what's actually fascinating is about 2/3 of our partners do nothing about HIPAA, because when you're a shelter provider, HIPAA is not something that is part of your language, and so the sharing. So part of it was we actually had to train everyone around HIPAA, and we brought in a number of attorneys as well as our own compliance staff to help do that kind of training. We weren't comfortable, to be honest, just with the OCA, and so we wanted the patients to make sure that they were making an overt decision about our ability to share information, which also included some information around substance use. So it was an enormous culture shift. Our patients actually are pretty comfortable with it so far. So though we have only a small cohort enrolled today, all of those folks were fine with the limited sharing of information.
No, I think that.
So first, let me congratulate you on doing your story, which really just sounds amazing. I want to ask you two questions. The first one is, as a behavioral health community partner, if you save money for Mass Health, you get some share of the savings. How that works, in the sense of like for every dollar saved, cost, would you get some of that?
Certainly within the context of the it's in ACO, but probably, yeah, but there are definitely, there's talk in the RFR about meeting performance metrics, that if, in the out years, maybe it's years 3, 4, 5, that if you are, there are accountability metrics in place that you might be able to share in success. I don't think they've unveiled what that looks like.
My understanding of it is it's limited. So I think the short answer to that, I believe, is no. That it's really through shared savings through the ACO. So theoretically, and it all depends on sort of how your relationship is structured with the ACO as well.
So how is your relationship with the ACO structured? I'm trying to wonder, right, the ideal thing would be as you show success, more money comes in so you can expand. So I'm trying to figure out if that's the way it's set up.
In behavioral health community partners, the ACOs are supposed to contract with every behavioral health CP in that area, so that we will have a relationship. If we're successful, we would have a relationship with each of the ACOs in that area. We have to contract with them, they have to contract with us, and I imagine that as we begin to show success, that we are a high-performing CP, that they might refer more patients to us and bring more our way.
Katie, do you want to jump in on this?
Sure. I mean, you guys are also part of the BMC the ACO, right? So your providers also participate in that ACO, which is another one. In the CP model, there is no shared savings. And some is at risk for quality measures.
The second question is, in your list of challenges, some of them were sort of internal, you have to figure out how to talk to each other. So, and some were external, gee, it would be good if the city and the state were able to do that. And I guess I'm sort of wondering, what on your list are the highest things that the city or the state could do that people would say to us, what should we push for? The internal things were not particularly great pushes. But external things, you know, it's a question of data sharing for ADP or something like that. It's something that we can try and do whatever we can about. So what on your list is sort of each piece is like you want to say, look, we really ought to be able to do this.
Well, you know, we're really excited that Mass Health is that social determinants of health adjustment to cap rates for ACOs and MCOs. I think that is, you know, that is a national model to be so proud of. But what we worry about at the primary care level is, okay, they've got an adjustment at the ACO and MCO level. How does that trickle down to providers? I mean, how are they spending that? Are they investing in services that actually address social determinants of health needs? And so we have been advocating for some time that ACOs and MCOs be required to show what the percentage of their investment in primary care services, you know, in order to see how they're shifting care delivery. Is it just going to stay at the hospital level or at the case management level? So if this money isn't getting trickled down to providers that are trying to make an impact on this really complex population, then you know that good planning may not have really worked out the way that that was envisioned. And other states are doing it. Rhode Island and Oregon, the ACOs and MCOs are being asked to report on their percentage of primary care spend. So I think that would be a good place to start.
And I would add to that, our ACO certification program will provide some insight both in terms of how ACOs are supporting primary care, but also how they're putting programs in place to address social determinants of health. And so we'll have more insight. It does not go, obviously, as far to mandate that certain percentages have to be dedicated, but certainly we'll have more insight into that program around how the different ACOs are approaching this. But it's a question that we are interested in as well.
I realize I apologize, I'll pass this up. I realize that, but in your answer that I'm not sure I understand the findings. So some of it comes directly from the behavioral health partners program, and then some comes through ACO contracts?
So the financing model that I explained earlier, that's Health Policy Commission grant financing. And then we are a bidder on the behavioral health CP program. And so that's, I'm not sure if what.
And as a bidder there, the ACOs then have the opportunity to work with you if they wish.
No, it's actually, the ACOs are mandated to work with all the community partners that are approved in their geographic area. And then it's really sort of a pass-through district dollars from the ACO to the community partners.
Is that mandated or no?
That is mandated.
That is mandated.
So there's a mandated element, which is a PMPM that comes through. It's district dollars that comes through directly to the approved community partners. But there could also be, in terms of the contract relationship between the community partner and the ACO, additional provisions around shared savings, or if the ACO overall is successful, we're going to cut you a slice of that bonus. But that is, as I understand it, not.
That's not formal. Okay.
And theoretically, what the ACOs and MCOs that we've met with to date have said is, if this is successful, they would be silly not to want to help build the program more, to sustain it beyond the 5-year
Comment. Thank you for that great presentation and good luck. It was really exciting to hear about the great work that you're doing, and we'll look to hear more down the road. So one question I had, one of the challenges you listed is is always finding patients. And it sounded like you get consent fairly easily from patients. So I guess I wonder, I'd like to know a little more about the challenge. And then the second part, you have an ambitious goal of scaling up from 60 to 1,000 in a year. So finding patients is a challenge. How will you do that?
It is a challenge for us. We're fortunate, I think, as Mary pointed out, in the city system and the fact that we're so decentralized as a program, and we have the ability to track things like bed lists to see where someone slept during the night. But the truth is our patients are fairly transient. In fact, we have a 50% turnover, so we're very different than a typical community health center practice, and then we have a large turnover. So patients thankfully move out of homelessness, but there's also a high incidence of things like incarceration, or folks just looking for a change of you can find more affordable housing, for instance, in Lynn and Lowell than you can in the greater Boston area. That said, and I'll just use, if I could by way of example, last year there was a meningococcal outbreak in Boston in the homeless community. Meningococcal disease often leads to meningitis. You tend to see it in college dorms more than any place else in the United States. We, in the 6 weeks during the outbreak, we actually were able to, within 24 hours of each new case, we were able to successfully prophylactically treat people. So we treated in the 6-week period 350 people who were exposed, and then did another 4,000 immunizations to the homeless community, including staff. So it's a wonderful network in terms of being able to come together, but we still need to work through a number of the logistics because of how our patients move around. And we do anticipate that we'll lose some folks, which is kind of historic for us.
We have a 5-pronged strategy for trying to find them that we're launching this pilot. We try to find them when they're hospitalized. That's like number one. If they're in the hospital, we'll try to consent them while they're in the hospital. We'll try to find them in the clinics. We match our patient list on who's coming in for primary care visits and try to catch them while they're in the waiting room. We try to capture them while they're in the shelter, so people can look at their census list now and say who slept here for services, and then we try to capture them if they're accessing other services, like if if they're getting mental health services there, then if they have a mental health visit, then we would try to again intervene while they're getting mental health services. And then we have a street team that, for those who aren't accessing services, they're sleeping on the streets, we have our street team that's, deployed kind of with the list in mind, trying to find out where these patients are sleeping and trying to get them to be a part of the program.
Thank you.
To Commissioner Lord's second question about scale, I wonder if you could speak a little bit about why, with 60 patients currently, you're kind of straddling. You have this initiative going on, but you have your everything else you've always done in a traditional way. You've got 2 partners who are not going to be deploying these metrics at their sites, but insist on staying part of the consortium, and I think are still committed to that. I wonder if that's a good intro to kind of how you think of this scale.
Yeah, sure. We're kind of ironing out the wrinkles. That's the beauty of this pilot, is that we're trying to get the systems in place. Case managers had to get hired, so we didn't have as many boots on the ground when we first started out because someone didn't take the job, and then they had to restart the hiring process. So getting the case managers in place, because that's the way that we're enrolling patients, that was really huge. Our data systems, not quite up yet. We have a few of our organizations connected to it, but the rest, there's all these instances of this care management software that is mind-blowing, that has to have a new workarounds to get into the data system. So we don't have, it's not quite up to where we want it to be, and I think once the, the IT system's in place and we have all the care management folks in place, will be ready to run full speed. And so, anticipating these challenges, moving ahead, if we're selected as a behavioral health community partner, we can, we already kind of built in a longer lead time, hire case managers like 3 months out rather than a month before. It's so we're already learning from our lessons, like, oh yeah, we should have done that. So
We will also, our partners, so all of the partners will be in for the behavioral health community partners. So the 2 that are on the sidelines right now, or 3, said that they would actually join as we enter into the behavioral health community partner. They will actually often shift the role of president case manager, so we'll be able to move that much quicker. Right now, they don't really have the steady funding stream for a number of the case managers that they have. So really what we're asking them to do is shift the focus, and that they will be receiving a PMPM for the first time. So as Mary said, this sort of feels like we're still working with our training wheels, and this is really sort of laying a huge foundation for us. Also, just to your earlier point, just wanted to mention that healthcare for the homeless, for good and somewhat pain in the tush. We were on Epic. We moved to Epic about a year ago, not quite a year ago, as our electronic health record. And because our 2 largest hospital partners are MGH and VMC, and we also have our clinicians practicing within the walls of those institutions, it allows us also to share information and to be able to track patients through those transitions of care much more cleanly than we've been able to do historically.
Well, thank you so much for being here today and sharing this early look into this work. I think we'll be checking back in at some point in the future as this continues to progress. But it's really exciting work, and thank you for your leadership on this.
thank you.
Yeah, really appreciate being here. Thank you.
Thank you, that was wonderful. So I believe we have any other items on the agenda. Since we do have a few minutes, let me ask whether anyone from the audience would like to offer any comments or ask any questions. If not, let me again thank our guests for coming, and we are adjourned until September.
Thank you.
She's not.